Hello, everybody. Today, we're going to have a very interesting discussion: alcohol, hepatitis, and cirrhosis of the liver. Now, when you're running across patients who have alcohol dependency issues or who've been diagnosed with a history of cirrhosis of the liver, it's important that you understand how to prescribe your medications and what to think about. Because overall their liver no longer has the capacity to process things at the same speed. And so you're going to have to select medications with shorter half-lives, select medications that's likely not to lead to any type of addiction, select medications that's probably can avoid the liver and be simply secreted through the kidneys, and also to avoid medications that would need to be a prodrug. Because if it's a prodrug, then your liver will not have enough cells to sort of release the prodrug to its active form. So if the liver is damaged to a way that it doesn't have enough protein to convert your prodrug to its active metabolite, then those medications may not work as well. So there's a few things to understand here in alcoholic hepatitis. So let's go ahead and just look at, let me just say here's chat GTP. Explain alcoholic hepatitis. Let's see what I have to say here. Okay, so pathophysiology, the clinical features, the laboratory features, histology, complications, management, prognosis. Hey, yep. Would you like me to include how alcoholic hepatitis different from drug or what you call it? Yes. Yep. Yes, let me. Okay, think about those while I'm up here. Okay. So here, alcoholic hepatitis is an acute inflammation of the liver caused by heavy and prolonged alcohol use. Heavy and prolonged. It represents a serious form of alcohol-related liver disease and can range from mild to life-threatening. Yep, life-threatening. Pathophysiology means what happens in the liver. The ethanol metabolism, the oxidative stress, the immune reaction, right? The fat accumulation, and then finally the cell death that leads to fibrosis, right? Leading to cirrhosis. Alcohol metabolism, the oxidative stress, the immune reaction, the fat accumulation, cell death, then fibrosis. See that? So that fibrosis, so cirrhosis of the liver is the buildup of that fibrous tissue. And so that means the liver is typically smaller and is less like a sponge, because of the buildup of the fibrous tissue. That's why it's cirrhosis of the liver, right? So alcohol metabolism in the liver produces aldehyde, a toxic compound that damages liver cell membranes and mitochondria. And it promotes inflammation and fibrosis, which is scar formation. See this, the buildup, the alcohol causes the buildup of acetaldehyde. It causes damage to the liver cell membranes, damage to the mitochondria, and it also promotes inflammation, which eventually leads to fibrosis. So that mechanism is the buildup of aldehyde basically leads to the scar formation. Oxidative stress. Alcohol metabolism increases free radicals which injure liver enzymes. Right? So the oxidative stress, alcohol releases. So first, alcohol causes buildup of acetaldehyde, which damages the brain cell and membranes and mitochondria. And then it also causes inflammations, which leads to fibrosis, there's a scar formation, and the oxidative stress by increasing free radicals that injure the cell. Then the immune activation. The damaged liver releases signals that activate inflammatory cells such as neutrophils, cytokines, and tumor necrosis factor. So now the immune activation, so now you have all the stress. Steatosis, fat accumulations because alcohol disrupt lipid metabolism. So fat accumulation, lipid metabolism. Then you have cell death and fibrosis that progress, possibly leading to cirrhosis of the liver. You see that mechanism right there? So I see the aldehyde buildup damages everything, the free radicals, right? Damage everything. Then the damage to these create an immune reaction that leads to an inflammatory response that eventually results in a disruption of lipid metabolisms. All this results in cell death and then fibrosis. And then that cycle continues to release itself until you have more cirrhosis of the liver, right? Sounds good. Clinical features. Symptoms can appear suddenly, often after a binge in someone with chronic alcohol use. Yeah, right. Jaundice. Yeah. Alcoholics like the jaundice in the eyes, the jaundice, the buildup of fat right here. Yeah, because alcohol disrupts the lipid metabolisms. Jaundice, right? You get that fever. I guess, abdominal pain, except the upper right. Clinical features, fatigue and weakness, yes, nausea and vomit, hepatomegaly, meaning enlarged liver. Signs of liver failure include ascites, confusion, and bleeding tendencies. All of these are the clinical features right there. Next, laboratory findings. The typical lab finding, AST is elevated more than ALT. Both elevated, but typically more than 300 AST to ALT ratio. So in alcohol, basically the AST is significantly elevated more than the ALT, right? And there's a reason for that, right? AST versus ALT, right? Elevated bilirubin, okay, a prolonged IMR, okay, indicating impaired liver synthetic function because it's not producing the albumin, right? Leukocytosis, leukophil predominance because of the immune response. Macrocytosis, that's enlarged red cells due to alcohol. Yeah, the macrocytosis on the skin. Elevated GGT. Okay, yeah. Okay, those are liver findings. The histology. Ballooned hepatocytes, which are swollen cells. Wow, swollen cells. Ballooned hepatocytes. Mallory-Dink bodies, damaged cytoskeletal. Mallory-Dink bodies, damaged cytoskeletal proteins. Neutrophil infiltration and paracentral fibrosis, zone 3 fibrosis. Okay, histology. Okay, so you have the histological changes. Complications, hepatic failure. Yep. GI virus bleeding. Yep. Ascites and spontaneous bacterial peritonitis. Yep. Hepatorenal syndrome. Yep. Kidney failure due to liver dysfunction. Yeah. Progression to cirrhosis and hepatocellular carcinoma. Yeah, so you can see this progression, hepatic failure, then you're not making albumin, so you get the GI, the bleeding, right? You're not making enough proteins from the liver, so you get the protein imbalance, so you get the swelling and all that stuff and the edema and things like that because you don't have the protein balance, and you're at risk of spontaneous bacterial peritonitis, right? You're also at risk of hepatorenal syndrome, that is the kidney failure, secondary renal dysfunction, and this can progress to cirrhosis and hepatocellular carcinoma. It's interesting how they come up with a progression of that. It's very useful. Management, absolute alcohol abstinence is the course of treatment. Yeah. Nutritional support, meaning high protein, high calorie diet. Corticosteroids used in severe cases based on measuring, okay. Pentaphoxylane, alternative if steroids are contraindicated. Management of complications such as lactose for encephalopathy, diuretics for ascites, liver transport for those with irreversible damage and abstinence. Prognosis, mild cases may recover with full abstinence. Severe cases, especially with jaundice and coagulopathy, have a short-term mortality. Severe cases such as with So jaundice and coagulopathy. So the jaundice means the fat disruption, the fat disruption in the fat metabolism, right? And coagulopathy is the disruption in the production of albumin and all those things that causes coagulopathy. So I guess when these huge systems fail, you have a high short-term mortality up to 30 to 50% at 1 month. Yeah, continue drinking leads to progression to cirrhosis and liver failure. Let me see here. This is very interesting to see here. Let me know if you have any questions, anything like that. Okay, let me see. Okay, would you like me to include how alcoholic hepatitis is different from viral or drug-induced hepatitis? Okay, how alcoholic hepatitis differs from viral and drug-induced hepatitis. Viral or drug-induced. Well, alcoholic hepatitis would be in drug-induced. Okay, that contrast often help clarify the mechanism and clinical management differences. Okay, sounds good. Cause. Okay, alcoholic hepatitis, then viral hepatitis, and then drug-induced hepatitis. Okay, the primary cause and then the mechanism action. So alcoholic hepatitis, chronic and heavy alcohol use, often over 80 grams a day for years. Okay, the mechanism of injury is toxic metabolites acetaldehyde, like we said, plus the oxidative stress creating the oxygen radicals, cause hepatocyte necrosis, inflammation, the battle cell death, the hepatocyte death, and then the inflammation. And then you have the immune response that activates, worsens the injury. Okay, that's the mechanism in alcoholic hepatitis. And okay, we went through that one. Okay, I did a previous lecture on hepatitis B. But I should have gone through the mechanism, how it destroys the cell too. So viral hepatitis. So it's an infection with hepatitis. It's a virus. Hepatitis A, B, the one I did is on hepatitis C. Okay, the virus infects hepatocytes. Okay, and then you have cytotoxic T cell mediated immune attack. It destroys the infected cells. So the virus infects the hepatocyte, and then you get a cytotoxic T cell mediated immune response that actually destroys the infected cell. So in alcoholic hepatitis, you get the buildup of acetaldehyde and the free radicals that damage the actual cells that results in inflammation, and then the immune response worsens the injury. In viral hepatitis, the virus in fact infects the hepatocyte that is recognized by the immune system, and the immune system initiates a immune response that results in the death of the cell. So you get the death of the cell through the immune response reacting to the virus infecting it. Got me? Okay, drug-induced hepatitis. Drug-induced hepatitis, medications or toxins such as acetaminophen overdose, isoniazid, valproate, mixed with methotrexate, and other psychotropics. All right. So these drug-induced medications, remember Depakote here is Depakote right here. Remember acetaminophen overdoses and everything is important to get cleared for those things. This is called direct toxicity, meaning dose-related, or idiosyncratic hypersensitive reaction damages to idiosyncratic hypersensitivity reaction damages to hepatocyte. And so the drugs damage the cells directly. Okay. It's interesting to know the difference between them. Okay, clinical presentation. Alcoholic hepatitis, viral hepatitis, and drug-induced hepatitis. You have the onset of alcohol is gradual or acute after a binge. You'll get symptoms of jaundice, fever, right upper quadrant pain, anorexia, fatigue, like the liver is not feeling well. History clues, long-term alcohol use. The course can progress to cirrhosis. Okay, so this is the onset and clinical presentation of alcoholic hepatitis. Let's look at viral hepatitis. Okay, onset, acute or insidious depending on the virus. So you can get the symptoms right after infection or they can develop over time. Okay, that's how I'm sensing them. Okay, because this is infecting the liver, we're going to see the jaundice, all right, malaise, nausea, dark urine, right? Okay, history exposure, meaning the viral hepatitis, there's a sexual contact history, a needle, travel, or food leading to the viral, right? And the course is often self-limited with chronic with if it's hepatitis B and hepatitis C. Hepatitis B and hepatitis C are chronic forms, and hepatitis A and E is more of the acute forms. Okay, now here, drug-induced hepatitis, acute or subacute after exposure. So you get the hepatitis after you use the drug. Jaundice, malaise, nausea, possible rash, and eosinophilia, because the rash and eosinophilia may become in reaction to the drug or the substance that the drug is coated in or something like that. History, recent new medications or supplements, if they came in with new medication supplements or overdose or something like that. Of course, it improves after drug discontinuation unless massive necrosis and everything. And so this is what we want to do, like definitely do things like the activated charcoal and things like that to treat them. And that's drug-induced hepatitis. So I think you can see the difference between them. Let me see laboratory findings here. We're going to look at the AST-ALT pattern, bilirubin, alkaline phosphatase, and other markers. For alcoholic, since AST-ALT is 2 to 1. Okay. Now AST is a marker for organ injury, but it's not specific to the liver, right? And so when you get other organs that can be under stress, you can get an increase in your AST. ALT is specifically connected to the liver, and we'll see the difference between these two and why it goes up like that. Okay, so here in alcoholic hepatitis is 2 to 1, bilirubin elevated, mildly phosphatide oxidase elevated, GGT and MCV escalated, increased. Viral, look, ALT greater than AST. Look, viral ALT greater, often greater by 1,000. And when you see this, this is a kind of dramatic presentation when you see this, because this is one of the indications that this is likely a viral hepatitis. Bilirubin elevated, ALK increase. Other markers, viral serology. Okay, get your hepatitis panels and things like that. Great. Next, drug-induced. ALT is greater than AST, and it can be very high for drug-induced. Depends on how much damage, right? Bilirubin elevated can be high, especially in cholestatic injury, eosinophilia, and positive drug reaction markers. And so you'll know from your history. Yeah, so remember the distinction between this AST, ALT, and then ALT-ASC right here in drug use. It'd be interesting for you to remember. Okay, histologic findings. Okay, pattern. I'm not really going to get into that, the histological patterns. Let me see, management. It makes sense. The management makes sense. Alcoholics, stop drinking, and you have to focus on nutrition. Viral, you're going to have to get your antivirals. Drugs, you got to stay away from the drugs. Prognosis, can be significant. And I think that's, we're at the 19-minute mark. I think that's it for today. All right, I think that's all I have for the day. Alcoholic hepatitis and cirrhosis. If you have any questions, please feel you can put something in the comment line. Otherwise, feel free to like, subscribe, and share. Read out. Take care, guys. Ciao.